Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
All right, spelunkers. Today's show is a continuation of my discussion with Dr. Matthew Wall, where we discuss psychedelics, the neuropharmacology, and all of the great things that could potentially be helped with these agents. If you haven't listened to the previous podcast, which this is the continuation of, I would strongly recommend that you go back to Season 3, Episode 10. Dr. Matthew Wall is a psychologist, neuroscientist, and a specialist in neuroimaging, particularly functional magnetic resonance imaging of the human brain. He completed his PhD at Cambridge University and then completed postdoctoral positions at Royal Holloway and UCL. He is currently the head of MRI applications at In Vitro London. He is additionally a senior honorary lecturer at the Imperial College of London and has authored more than 70 scientific publications. He's an editor at Scientific Reports, which is a very prestigious publication, and his research focuses on psychedelics, cannabis, sex hormones, and methods development for functional MRI. Without any further introduction, please enjoy this continuation of this great discussion that I have with Dr. Matthew Wall. Has there been any insight into why these thirds act differently as far as?
Well, it's a good question. So there's people talking about why that might be the case. There's some ideas around about genetic differences in the 5-HT2A receptor.
Okay.
Possibly, a number of other genetic or behavioral or physiological or social factor. You could make up a lot of things. People are definitely interested in that, though, in terms of this kind of precision psychiatry approach, if you like, where you're trying to stratify people.
What about the good trip versus bad trip? Does that factor into this third breakdown? I mean, are the people that don't respond, maybe they had a bad trip, or what's your take on that?
That's a tough one. I mean, a lot of the patients in the studies that I've been involved with anyway, they tend to have quite a difficult time. They often they have, what we might call a challenging experience.
Okay.
With the drug, because they are encouraged to think about the source of their issues, to introspect, and for a lot of people that brings up things that they would rather not engage with. But and a lot of people have some anxiety during the process. I mean, anxiety is the main adverse event, if you like, that you get with these drugs, but it tends to be transient. It tends to go
very short term.
Yeah. I don't think from the data that we've got already, I don't think that the emotional valence of the trip itself, if you like, is that predictive of the clinical outcome. And in fact, I think probably maybe the subjects that engage a bit more with their trauma or their problems and have maybe a bit more of a challenging time might be actually better off because of that. Yeah,
I guess
I don't think.
it's opening the can of worms more, so more can get out. While that may not be a
Yeah,
pleasant experience as much as,
yeah.
that's very interesting. So you mentioned PTSD, and we see in our histories of patients with chronic pain,
Mm,
and I don't have a statistical number, but it's very high that if you dig down deep enough, they've had some type of traumatic event. A lot of females that are in chronic pain have had some kind of a very adverse sexual assault or molestation. I mean, it seems that these very horrible things that happen to folks kind of predisposes them to chronic pain. And, so I
yeah,
guess we've gone into the pain world a little bit. Let's talk about PTSD and
yeah.
pain.
Well, I have a friend of mine, Dr. Ben Sessa. He talks about, he's a proper clinical psychiatrist. Unlike me, I'm just a research psychologist. But his take on all of this is that everything is trauma. So if you
Okay.
have if you have a difficult childhood, say, or some traumatic event in your early life, that will manifest at some point, and it might manifest as addiction or obsessive compulsive disorder, or as chronic anxiety, or as depression, or as chronic pain.
Mm-hmm.
But all of these things are just a reaction to that that underlying trauma, if you like. And he's done a lot of work with MDMA therapy, and he thinks that it's the best way of actually, no matter what the diagnosis is, whether it's depression or chronic pain or OCD or whatever,
Mm-hmm.
and you can get at the root problem with MDMA therapy related to the original trauma. So that doesn't surprise me when you say that you've seen patients with chronic pain with a trauma background.
Yeah, no, unfortunately, it's very, very common.
Mm.
Well, let's talk about some of the because you mentioned anxiety as an adverse event. There's been tremendous amounts of propaganda by our U.S. government. I don't know how it is in Britain about how horrible these agents were back in the 60s, and people were running down the hallways and jumping out of 30, story skyscrapers and all kinds of wild stuff, and how MDMA dissolves all of the neurons in your brain, and there was wild stuff that, what's the real take on the safety of these agents overall?
Well, I mean, the classic psychedelics are incredibly safe, pharmacologically speaking. So you have to take 1,000 times the normal dose, or something ridiculous to have any kind of toxic effects of these drugs.
Okay.
Now, you would have a pretty weird time if you did that.
Right.
But it wouldn't be dangerous.
Right.
Obviously, there's dangers when people are using these things recreationally, when people do stupid things like take a big dose of LSD and run out into traffic, or
right.
So recreational use is one thing, but clinically these are really incredibly safe drugs if they're done in a in the right environment with the right clinical support around you. There is really no danger of any serious adverse event, serious kind of biological event, if you like.
And I think the functional MRIs would support that, right? I mean, if you had an agent that knocked out regions of neurons, you certainly would see these very detrimental effects on a functional MRI down the line post administration.
Absolutely.
So when they say, go ahead.
There have been studies. I mean, MDMA was a big thing in the UK around the early 2000s. A lot of scare stories in the media. And that kind of thing. And there have been studies, quite a lot of studies done on chronic MDMA users, people who have been, taking high doses of MDMA every weekend for the last 10 years. And, you can find maybe some little differences, but it's nothing nothing clear really. Some studies have found differences in the brain in this area, and other studies have found differences in another area, and so on and so on. And there doesn't seem to be, unless you're really abusing these things in a very chronic way for a long time at high doses, there doesn't seem to be a huge detrimental effect at all.
Well, and then the other question that I would have in the quote recreational use arena is, are they getting an adulterated drug that may not be what they think it is?
Exactly. Yeah.
I think I recall one of the studies that our government used to demonize MDMA. They were actually using another agent. I forget what it was. I think it was an amphetamine.
Yeah, it was methamphetamine. Yeah.
Yeah. It's like, what kind of bullshit is that, right? You're going to tell us a drug is bad based on a study that you did on another drug?
Yeah.
I mean,
that's wild stuff.
Yeah, it's very disingenuous, incredibly. Yeah. So from an adverse reaction, then it's, probably pretty safe. And I think you made a great point that these are clinical applications, settings with the right psychotherapy. They're not just grab your bag of mushrooms and head out to the hills and open the bottle of picnic wine and have at it. It's as everything, I mean, if you look at drugs over the whole spectrum, not just psychedelics, I would proffer that if they're used for the proper indication and at the proper dosage, generally speaking, they're pretty safe. It's when people use them in a less than ideal manner that they get in trouble.
I mean, honestly, even recreationally, with recreational use, with all the problems with, it being adulterated with other things, there's, estimates vary, but let's say there's 500,000 ecstasy pills taken every weekend in the UK. Okay. And there's, single digit deaths, in a year attributed to MDMA, usually when people have been drinking alcohol or mixing it with other things as well, Right. So, I mean, even recreationally, even with the problems with clean supplies and things like that, these are still incredibly safe.
So then the next place that I would go is the addiction potential for these agents probably is extremely low, other than maybe somebody likes having their ecstasy on the weekend and they feel great, so they take it and they continue to take it, but it doesn't really develop a pharmacological addiction, so to speak, right?
Yeah, they seem not to be, well, particularly the classics, LSD, psilocybin, they seem not to be addictive, in the standard way that other drugs are addictive, amphetamines, cocaine, and so on. Yeah, they don't seem to have that strong dopaminergic effect in the regions like the striatum, which tends to happen with these other drugs.
So why did psilocybin surface as one of the more studied psychedelics in today's times versus maybe some of the other agents like LSD or like ibogaine? What is it? The availability of it, or is it the pharmacological profile? What do you think on that?
Well, it's two things really. So having talked to the people who were doing this in the really early days, I mean in the early days of this new wave of research, if you like, because there was a lot of stuff done.
The modern early days.
Yeah, okay. The modern early days. So the early 2000s.
All right.
So I know David Nutt talks about this, and he says that there was so much kind of propaganda and stigma around LSD in particular, that they decided for their first studies, okay, well, we're going to use psilocybin because nobody's heard of psilocybin. Maybe they've heard of magic mushrooms. And they thought that would perhaps be easier to get through institutional review boards and ethics panels and so on. The other thing about psilocybin is it has a bit of a different pharmacokinetic profile. So, a psilocybin trip, you can dose people, and then you're talking about maybe a 4, 5, 6 hour trip.
Okay.
So you can do that quite comfortably in a kind of working day in a clinic.
Right.
Whereas with LSD, you're maybe talking 8, 10, 11 hours,
Okay.
which is a long day for the subject and for the
Clinician.
clinicians who are
Right.
working.
Right.
So it's a bit more convenient. People are really interested in the other classic psychedelic, DMT, at the moment.
Okay.
And DMT is extremely short acting. So if people recreationally will smoke DMT, and it lasts 10 minutes.
Okay.
You're up and down again, and you're pretty much straight again after about 10 minutes. And there are ways that you can extend that experience a little bit by doing infusions and other things. But people are quite interested in that aspect of DMT because it's just so much easier to have a short acting experience. And we don't know if that's really going to give us the same experience that people have with psilocybin, whether that longer period is really necessary or not. But people are trying to figure that out at the moment. But if DMT works as well as psilocybin for depression, then that makes kind of actually administering these treatments on a larger scale quite a lot easier, because you could do, a couple of sessions in the morning and a couple in the afternoon, rather than having been tied up for a whole day with one patient.
And DMT, is that the same as they get from licking the back of the toad?
So there's N,N-dimethyltryptamine, which it comes from, you find it in a lot of places, but it comes from, it's plant based basically. And then there's 5-MeO DMT, which is the one you get from the toads. Yeah.
Okay.
And they're both psychedelics. They're both classics. They're a little bit different in their effects. 5-MeO lasts a little bit longer, but they're quite similar. Yeah.
Okay. All right. So if you see somebody licking a toad, they're just doing their daily dose.
Yeah.
What about the research that you guys are doing right now and big pharma? Is big pharma pushing back against y'all? Because you can't patent psilocybin, right? LSD was created in 1938 by one of the big pharma companies. So that patent has certainly expired. Is there a pushback from big pharma?
Well, so big pharma haven't really dipped their toe into this space yet. So there are a lot of commercial companies, most of which are quite new and have started up in the last 4 or 5 years. But they're all fairly small kind of biotech startup things. There's a couple of bigger ones, but mostly they're pretty small. And actually last week I saw some news about one of these companies actually being bought up by Otsuka, which is a big Japanese pharma company. I think that's the first acquisition I've seen of one of these startup companies by a proper big pharma. But you're right, the kind of intellectual property issues in this space are quite difficult. And I think the reason that big pharma's holding back is because nobody's really got a viable business model yet. First of all, like you say, you can't patent these things. And second of all, if these things pan out the way that we think they'll pan out, you end up curing people with a couple of treatments.
Right.
Well, that's no good. You can't make any money like that.
Right.
You want to sell people a pill for the next 25 years.
Exactly.
Yeah. So while it's great for patients, or it may be great for patients, we hope it's great for patients, it might not be good for big pharma. So yeah, I think big pharma are kind of holding back at the moment and waiting to see how this all shakes out.
Are they holding back, or are they restraining at higher administrative levels within the governments? Because it seems like there's been a tremendous amount of very compelling research that's been done in the psychedelic arena, not only in the UK where you guys are, but here, Johns Hopkins, Emory here in my home state of Georgia. There's lots of centers that are doing very meaningful research and having unbelievably great findings. How long is it going to take for these bureaucracies to finally acknowledge we've got huge problems with depression? We can't wait for big pharma to design a new drug that they'll take for 50 years every day of their life. Why not, let's get this out there and deregulate it.
Well, I think it's close. So, I mean, there are two organizations that are really pushing this. So both in the US, actually. So there's an organization called MAPS, which is the Multidisciplinary Association for Psychedelic Studies. And MAPS is actually one of the old ones. It's been going for a very long time, with the aim of they focus mostly on MDMA for post-traumatic stress disorder. And their aim for about 20 years has been to get MDMA through the FDA as a recognized treatment.
Right.
And they are pretty close. They've done a couple of big phase 3 trials. They've showed it works. And I think the expectation is that they'll be able to make a submission to the FDA for approval probably next year.
I had seen,
which is great.
I had seen something about a year ago that the FDA was considering, approving psilocybin here in the US, and it was supposed to be like the fourth quarter of 22, and then nothing happened, and it just kind of went quiet. So I was wondering about that.
So the other organization is a company called Compass Pathways, and they're focusing on psilocybin for depression. And again, they're pretty close. They're on the way to making a submission to the FDA as well. But the states actually seem to be running ahead a bit. So in the legal terms, so that there's been a couple of states, Colorado, Oregon, California, are all kind of debating this stuff at the moment. Some of them are debating whether to kind of relax restrictions on these things to allow more research, or to allow research to happen more easily, which would be great. Australia is actually the leader in this field. So as of 1st of July this year, so just a couple of months ago, Australia has medicalized psilocybin and MDMA. So you can now, in Australia, you can go to your doctor. There's only a few doctors who are doing it at the moment, that they need to train more people and so on and so on. But in theory, you can get prescribed psychedelic therapy in Australia.
Is there any place else? Because I know in the United States, I believe it was just a few days ago, California passed a bill, or at least sent a bill to the governor's office to decriminalize psilocybin. And I don't know if that's been signed into law or not, but I know Oregon has passed a law that, as of I believe it was this January of this year, that clinicians could actually start setting up clinics and treating using these agents, or at least psilocybin as a clinical agent. I don't know what Colorado has done, but they've also done something like that. Is there any place else in the world that you can go to and say, listen, I've got severe depression or severe PTSD. I can't get into one of these research studies. I've tried to send a couple of patients to Emory that I thought would have done very well on some of these agents, but COVID kind of really shut down a lot of the research efforts. And then, and then just getting them in to a research study is really very difficult. Is there any place in the world, Matt, that they can go?
Yeah, I mean, there's a couple of places. So there is the Netherlands, Holland, where psilocybin mushrooms are still illegal, but for some reason, psilocybin truffles, which is the underground part of the mushroom, the bit that you don't see sticking out of the ground, they're still legal. So there's been a few people setting up retreat places in the Netherlands where you can go and have the experience and talk to therapists and things like that. There are similar places in Jamaica as well. And Jamaica, for some reason, never got around to criminalizing psilocybin, so it's always been legal there. I guess they never had a particular problem with it or whatever. So there's a few people that have set up similar things in Jamaica. I kind of hesitate about recommending those places to people, because they're not. I don't know exactly how they're organized and set up. I don't know if they actually have qualified clinicians working there.
Right.
It might just be a couple of hippies in a field with a teepee. I don't know exactly. but there certainly are places you can go to do this. There's quite a lot of these places in Mexico as well, where I don't think it's legal, but I think it's not really enforced.
Right.
But again, you know, I hesitate to recommend people check out these things because they are completely unregulated. That's
Right.
the point. And you know, I've heard a lot of good things about these places.
Right.
But it is a bit of an unknown.
Yeah, no, I'm sure. Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor. The Pot of Inquiry has a new sponsor, Pop Souls. Folks, these are really cool and will be so valuable in your day-to-day practice. Think back now. How many times have you been in that busy clinic session and you really needed to give that patient some method to offload a part of their foot that you just worked on, but you don't have time to pull out the off-the-shelf insert out of the closet, find materials to modify it, get glue all over your hands, and then dispense it to the patient. But you really would have liked to have offloaded them. Say, for example, you just finished treating your heel pain patient with that peptide infiltration of BPC 157, and you'd like to offload the inferior calcaneal aspect for them for a couple of weeks. Well, now you can with Pop Souls. They are very easy to customize in literally seconds, and this gives that patient an effective and efficient way to offload for a more optimal outcome for any procedure that you do. All you have to do is hold up that innovative little insole to the bottom of their foot, mark the area to be offloaded, and pop the little chambers. That's it. The Pop Sole has some really unique features. They are easily transferable between one shoe to another. They provide versatility. You can use the bubbles up to enjoy walking on air and get that neurosensory massaging feel of the bubbles. Or you can flip it over and use the smooth side to enjoy the buoyancy of the bubbles. The patient can further modify them if needed. They have a discreet design. You can use them in sensible shoe gear and with removable insoles. I have tried these little devices myself and can tell you that they really work, and it is so simple to get them ready for yourself or your patients. Pop Souls is offering the Pod of Inquirer listeners a 15% discount with the code POPPOD15. That is POPPOD15. You can get more information at their website, popsoul.com, or you can always find them on our sponsor page at podofinquiry/sponsors/. Start implementing these today in your practice for more efficient and better patient management. I know you will be glad you adopted the Pop Soul insert into your practice armamentarium. Isn't it ironic that, you know, we've had this war on drugs where, and that war has been tremendously lost, at least here in the U.S. But you have these agents that can get astounding results when you talk about getting people out of their addiction, whether it's alcohol or tobacco or whatever. I mean, think about, it's just so ironic. You could deregulate these and probably get rid of a lot of the other problems. So you would be winning the war on drugs by approving these agents.
Yeah.
The way I'm looking at
it. It's really ironic. I mean, the war on drugs came out of Nixon's time as president in the late 60s, very early 70s. And and it was a lot of that thing at the time was really about the American establishment having a real problem with the counterculture movement at the time,
right,
which they thought, you know, was linked to the Vietnam War protests, which were, you know, a big deal at the time. And a lot of that was clamping down on these filthy hippies, you know,
right,
who were into that kind of thing. And it turns out that actually these things can be, you know, incredibly helpful in lots of ways. And you know what really annoys me about the war on drugs, because Nixon came up with this thing and then got this resolution passed through the United Nations Security, the United Nations General Assembly, which basically every other country in the world adopted, with a few exceptions, to ban these things worldwide.
Right.
And then in the last, I don't know, 20, 25 years, actually the US has been pretty relaxed about these things. You know, medical cannabis has been a big thing there for 20, 25 years. But the rest of the world for some reason, or a lot of the rest of the world, particularly the UK where I live and work, is still stuck in this war on drugs mentality.
Right.
So the US kind of exported this mindset to the rest of the world.
Right.
And then shortly after, I kind of rode back on it and has started deregulating things. But the rest of the world still hasn't caught up, unfortunately.
Now, you mentioned cannabis. I want to get to cannabis. I see you published some stuff on cannabis, and I mean, we, like you said, we've had medical marijuana here for quite a period of time. I think it's about 35 states now either have medical marijuana or just recreational use. We were very involved when Arizona passed their medical marijuana law back in, maybe 2006, 7, in that neighborhood. It was a long time ago. But we saw really from a analgesic standpoint, tremendous benefits with medical cannabis. And so some of these, I mean, I had patients that were on like 900 milligram equivalents of morphine a day. And after 3 months, they were down to 50 or none. And it made a big difference for them.
That's amazing.
Yeah. And again, the safety, we never saw any adverse effects from a safety standpoint. And, again, people didn't abuse it. And they weren't trying to get high. They were just trying to get out of pain.
Yeah.
It's just a difference.
What's amazing about, if you look at all the states and you look at when they relaxed the restrictions on cannabis, I mean, I'm sure you know opiate overdoses are a huge problem. The opiate epidemic all across the US. If you look at the states where they relaxed the restrictions, or where they even kind of legalized semi-legalized recreational use, you see that opiate overdoses just drop off a cliff at the same time that cannabis gets legalized. Yeah, people are able to switch. Yeah, even if they're heavily addicted to opiates.
Right.
They find that cannabis helps them take the edge off in the same way.
One of the things that I've seen in my clinical experience over the last 30 years, and I've talked to, some very prominent people in the opioid world about this, is that a lot of these folks are not really addicted to the drug from a pharmacological standpoint, but they are dependent upon it because it allows them to function at a normal or nearly normal level with their pain. And if you're able to remove the pain generator, then they don't want to take the opioid anymore. And in fact, some of them I've had problems with because they just discontinued it after being on high doses, and then they would go into, cold turkey and very bad, physiological responses to that type of discontinuance of these agents. But it's kind of interesting how the dependence may not be an addiction dependence, but just a dependence upon the fact that I'm not in pain when I take this. I don't want to be on it because it constipates me and it does all of these other bad things. But so I don't see any hurdle to conceptually agree with what you just said, that it's going to drop these opioid deaths and abuses tremendously. Let's go back to microdosing, because there's a lot of talk and there's some rumor. I don't know how much this is true, but in Silicon Valley out in California, where you have all of these startups and these techno wizards and entrepreneurs, that there's a tremendous amount of them that microdose either LSD or psilocybin in order to have higher executive function. Is there any merit to that, or is that placebo? What's your take on that, Matt?
I'm quite skeptical about this. So yeah, you're right. The microdosing thing kind of came out of the Silicon Valley type culture, where people are maybe into the kind of biohacking type stuff, optimizing their performance and taking 1 million multivitamins every day. So yeah, people normally take between 1/10 and 1/20 of what you might call a normal dose of these things. So if if say a normal dose that you might take recreationally or even clinically of psilocybin is say 30 milligrams, then you might take 2 or 3 milligrams. And you don't get any perceptual effects. Right. It doesn't seem to have any kind of the normal hallucination effects because it's a tiny dose. It's an inactive dose, but people claim lots of things about microdosing, that they're more creative. It helps them with their anxiety or their depression. It helps them focus. All kinds of things. Helps them sleep better. I just from a kind of pharmacological perspective, I can't really see how it works, because with every other drug that we know about that affects the brain, in order to get some kind of psychological or clinical effect, you have to occupy a certain percentage of the receptors.
Okay.
For instance, kind of dopaminergic antipsychotic drugs. Okay,
right.
There's a threshold. If you're hitting 65-70% of the dopamine receptors in the brain, you're going to see some clinical effects. If you're below 50%, it's not going to do anything.
Okay.
Which makes sense. You've got dosages, everything with pharmacology. One thing can be helpful or it can be a poison depending on the dose. And so with microdosing, say you're hitting 10%, 15% of the 5-HT2A receptors in the brain, I can't really see how that is producing any measurable effect, because that's just not how drugs work.
Has there been any functional MRI studies on microdosing?
I don't believe so. So there have been a few studies where people have looked at microdosing. There's quite a lot of kind of survey data and things like that, where people have asked microdosers, how do you feel on the day after the day you do a microdose? People tend not to do it every day. People might do it twice a week or 3 times a week or something like that. And there have been some cool studies where there's one study by a colleague of mine at Imperial called Balash Shigeti, where they did this kind of self-blinding citizen science project, where they got people who were going to microdose anyway, and they got them to blind them. They did this complicated thing where they got them to blind themselves, so they didn't know if they were taking microdoses or placebos.
Okay.
And what they found in that study was that if people thought they were taking the real microdose, then they had an effect. And if people thought they were taking the placebo, then they had no effect. But it actually didn't matter whether they were taking the real drug or the placebo.
Right.
So it was basically all placebo effect. And that tends in all the best studies that have been done so far, that tends to be the pattern. So you don't really, you might see some effects, but they're not really distinguishable from placebo effects.
It's very interesting how powerful the placebo effect can be. And you can look in the literature and you can see some things about how doctors convey to their patients the benefits of taking a drug. And there's this, I forget exactly what they call it, but basically you're creating a positive expectation in the patient's mind. And when you do that, then they have a better, whether they're taking a placebo or not, even with the real agent, they have a better response. I forget what that's called. You guys have a model for that in psychology. There's
don't know.
But anyhow, regardless, so you can tell a patient, hey, this drug is new. I have no experience with it. It might be good for you or it might not. Why don't you take it? Versus if you tell the same patient, this drug has incredible benefits. The studies have shown X, Y, Z, blah, blah, blah. The effect of that administration is going to be better than the mediocre presentation. So I think there's some merit in that, but
there's all kinds of weird stuff like that, like big red pills, like pills the size of a quarter that are bright red, are much more effective than small white ones, even if they contain exactly the same amount of active drug and things like that. Yeah.
I think Big Pharma studied the color of pills just for anxiolytic agents. They found that light green or blue were more soothing than the black pill or something. I don't know. I don't know. It's pretty crazy. It's fascinating stuff. So I wanted to go back to trips a second. So if somebody has a bad trip, doesn't necessarily equate to a bad outcome down the line. Did I get that correctly?
Yes, I think that's right.
Okay. And then if they've had a bad trip, does that preclude or obviate any future administration where they could then have an okay trip?
I don't think. I mean, we haven't really engaged with that. I think because I mean, all the clinical trials we've done have been kind of discrete entities, so we haven't had people coming back again after some time. But I don't think it would. No, I think if you have a challenging experience with your first one, I don't think that would necessarily preclude you from having further treatments.
Okay. Now, what are you?
Unless it was really extreme and you ended up with, some
Right.
terrible anxiety issue.
Right. No. So what are you guys looking at now? What's the state of your research? Because it seems like you're producing a lot of work.
Yeah. So we've got some data that we're writing up at the moment, which is in the psychedelics world. We've got some data which is we went back to our roots a little bit and looking at healthy subjects again. So we're really interested in the physiology of this persisting effect.
Okay.
So you have the acute effects which last a few hours, and then you have these clinical effects which last for weeks or months. So we've scanned a bunch of people and we scanned them, healthy subjects, baseline, and then a couple of days after the trip, and then 4 weeks later.
Okay.
So we're interested in looking at the physiological, the brain effects of this persistent effect and trying to tie that down a bit. So we're writing that data up at the moment. That's quite exciting. We've just finished another clinical trial where we're looking at psilocybin therapy for anorexia nervosa, eating disorders.
Okay.
And that's been a difficult study. Patients with eating disorders, they can be, they're quite a vulnerable patient group. They're quite sensitive to a lot of things. A lot of kind of other issues around that, but that's turned out pretty well. We have this is not a study that I'm involved with, but my colleagues at Imperial, they're not doing brain scanning with this one, but they are working on a clinical trial of psilocybin therapy for chronic pain with fibromyalgia.
Yeah. So what are they seeing in that? I'm very interested in that.
They're still partway through the study, and
Okay.
I don't know, to be honest, but there's something they're actively working on at the moment. So yeah, that's exciting. And the cool thing about these drugs is the kind of transdiagnostic nature of them. Okay, because they have this very general effect, this shaking up of the snow globe, if you like, this
Right.
flattening of the brain's functional organization. You then can tailor the therapy component of it to a lot of different disorders.
Okay.
Basically, in theory, kind of any disorder that's characterized by kind of repetitive or ingrained patterns of behavior. So things like eating disorders, addiction, rumination in depression. We think that they might be really helpful in all of these disorders. We've just got a little bit of money from the UK government to do a little pilot project for psychedelics for gambling addiction as well.
Very interesting.
Yeah. So yeah, it's a busy time.
That brings me to a question, and you may not be able to answer this, but if you had one agent, which agent would it be for which specific condition that you think has the greatest success rate or promise? I know that's a very ethereal question, but I think you understand what I'm asking you on that.
Yeah. Well, I've been talking about a lot of clinical stuff on this podcast, but I should have said this at the beginning. Really, I'm not a clinician. I'm a researcher. I've been talking about what I know from being a part of these trials, but my colleagues are psychiatrists and proper clinicians, and they've been doing this. And if you ask my colleague Ben Sessa, who I mentioned before, he would say instantly MDMA. He says MDMA is the perfect drug for psychiatry. Nobody has a bad time with it. Nobody has a bad trip on MDMA.
Okay.
Like never. It allows you to do all kinds of things in the therapy that you wouldn't normally be able to do. And it works really well. So that would be his take. Yeah. Other people are more into the idea of the classic psychedelics, where you have the very intense hallucinatory experience, and that's producing the clinical effects. For me, I don't know.
Yeah, no, it's interesting because some studies are looking at addiction, and some are looking at PTSD, and some at pain, and you have all of these different parameters. And in truth, if you overlaid all these conditions, it's like a Venn diagram. There's a lot of overlap. It may manifest as anxiety in one person and super depression in another, and they aren't that dissimilar. So it's kind of interesting. But that's why I just wanted to ask you that question. And it seems like it has multiple there's multiple conditions that can be addressed because you speak of the generality of these agents. So that's kind of what I wanted to get. Anything else we need to know about psychedelics? This has been very fascinating, and I really appreciate the work that you've been doing in this space, and hopefully we can translate this into clinical applications more over the next several years. Because I think
I mean that's the hope. I mean, there are big challenges. So I mentioned earlier the MAPS organization, who are pushing for the MDMA, to get MDMA through the FDA. So the head of that organization, a guy called Rick Doblin, he said recently, if we get this through, the demand for these treatments is going to be so big that we're going to need to train 100,000 MDMA therapists over the next 10 years.
Right.
Because I think there is demand for these treatments.
Oh, absolutely.
And I think that's helpful in a way, because I think that helps to push things from on the legal perspective of getting these things.
Right.
That kind of demand from the general public helps to push the politicians in the right direction.
Right.
But I think there is a lot of pent up demand for these treatments, and I think it's a case of when, not if, particularly in the US, they do become legal. I think it's going to be a huge challenge in scaling up these things and actually having people be able to access them.
Right.
That's the big challenge for the future, and figuring out how we turn them into kind of viable long-term treatment strategies. Like I was saying, do we give a booster every 6 months, or
right,
that kind of
thing? And I don't think
think
you're going to get those answers until you see a widespread clinical implementation, because there's a tremendous amount, and I'm not trying to denigrate the type of like true scientific research that you guys are doing in a very controlled scientific, but there are a lot of benefits from multiple case studies, even though they can be considered anecdotal. But what this group learns over at this center from their clinical observations, and this group over here, now they can marry these different findings together and craft different administration regimens and, maybe patient selection criteria, all of these different things that are going to optimize eventually. So I think that the research that you all are doing is so foundational to get it to that point. But then once it does get into a widespread clinical use, then that is going to feed what you guys are doing even that much more from a research.
Sure. Yeah. I mean, the clinical trials that we've run, they're small, they're 20, 25 subjects,
right.
Very controlled, a lot of patient contact. It's not the same
right.
as it's going to be in the real world. And, we've been, in fact, all the clinical trials so far, we've been very careful about patient selection, particularly around any history of psychosis or bipolar disorder, or even any, immediate family history of those things. Because there's this there's this caution, I think, with these things about using them in people who might be predisposed to that kind of different class of disorders: psychosis, schizophrenia, bipolar.
Is that more theoretical, or has there been some significant
Well,
observations?
I think it's just general caution, really.
Right.
From back in the day, back in the 50s, 60s, when people were using these things, and there was some cases of people ending up with psychotic related issues. But as these treatments get more widespread and more available, we're going to have to grapple with that a bit more. I mean, are we really going to restrict these treatments to people with no history of that kind of thing and no family history of that kind of thing? There's lots of questions unanswered, for sure.
And it may be counterintuitive. It may actually be beneficial in some of those patients. Who knows, right?
There are some people who are saying, well, maybe we should try it with psychosis as well. Yeah.
Right.
I'm not sure. I don't know.
Yes. Well, those are questions that may be answered just by the vagaries that are implicit in clinical research, where you see a large number of patients like, 4 or 5 of them slipped through that had schizophrenia. It's like, oh shit, we didn't screen them out, but look at the effect that they had, right?
Yeah.
So sometimes, sometimes the clinical arena is tremendous for, making these types of observations and all.
Yeah.
Fascinating stuff. I tell you, I can't tell you how much I enjoyed this. I love what you guys are doing over there. Keep doing it. And Matt, thanks for coming on. I really appreciate it.
Oh, thank you so much. That's great. I really enjoyed it too.
Well, folks, if you are over 40 and you are not using a supplement to augment nitric oxide production, you should really think that. This molecule is absolutely imperative to health, not to mention its cardio protection. If you have any question on nitric oxide, I suggest that you go back and listen to the Pot of Inquiry, Season 1, Episode 3, for my conversation with one of the world's experts, Dr. Nathan Bryan. I never miss a day of nitric oxide supplementation. That's how important I believe it is. Long overdue, there is now a nitric oxide replenishment formula without the fear of oxalates. Approved Medical Solutions does not use beets, spinach, or arginine. Approved Medical Solutions is proud to offer our audience their oxalate-free nitric oxide formula. If you are not a healthcare provider, you can still get started by going to approvedmedicalsolutions.com and use the code SBarrett, all lowercase, at checkout, and you will receive a 10% medical discount savings. For licensed practitioners, go to approvedmedicalsolutions.com and register. They have unique bundles for all of the full-fledged spelunkers of the Pot of Inquiry. Use Pot of Inquiry at checkout after registration, and I'm certain you will be pleased not only for yourself, but all of your patients. Here's a little secret. If you order their testing strips and test every patient for a few clinic days, you will see every one of those patients will be nitric oxide deficient. When they see this result, they will want you to start them up immediately. Now, thanks to Approved Medical Solutions, you can give them the best care without the worry of oxalates.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, potofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pot of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pot of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.